Dear students, as this is the second part of my knee joint presentation, the first part has been completed and I'm sure you have seen it. And now this is the second part. So just recap what we talked in the first part. Knee joint we talk about it's a hinge type of synovial joint, but it is a modified hinge. And this joint has a lot to talk. There were so many ligaments we have mentioned. I have emphasized on main major structure. I have not gone into minor details. I stayed more with the main ligaments, which are primarily and really responsible, and they cause problem for our day-to-day issues. And this joint has been involved in sports injuries as well as with the aging people. So we can see a lot in that. Now this section of my presentation is primarily covering the injuries, how to evaluate these patients, and how to look for different remedies. Definitely I'm not talking about the treatment options and all that because that's beyond. So now to start the ball rolling, I'm not putting time on the revisiting of anatomy. Just to say, by saying three words, we have three pairs of ligaments. One set of ligaments are placed in the sagittal plane and they are responsible for the rotational activity. They are my ACL and PCL. Two ligaments, they goes parallel to the joint. They are arranged in the coronal or the frontal plane, and they are my lateral and medial collateral ligaments, and two ligaments are placed transversely. They are more cartilaginous and they are shock absorbers, and these are called menisci. They are famous and we talk about those. Now, this is an x-ray of the same, and there you are looking at the lower end of the femur and upper end of the tibia. Look, fibula has to do nothing with this joint, which is known as the knee joint. Now, this is the upper surface of the tibia, and you can see that how the menisci has been organized and how the cruciates have been and you can see from the side view, these are the, you're looking at, this is the, which side it should be, it's the fibula. So this is my medial collateral ligament or tibial collateral ligament. Fibular collateral ligament has not been shown in this image. Now, coming forward, these are the normal x-rays. You're looking from the front, this space has to be there. And this is the intercondylar eminence. And look at the side view, and there is another joint between the patella and the lower part of the femur. That's a separate. We are not talking about that joint. We are only focused for this knee joint. So I hope things are fine. Guys, this is called anterior posterior or AP view. And you're looking from a side, so it's called a lateral view. Now what happens? Think. What went wrong? Yes, this knee has been dislocated. And you can you see this whitish line? This is some type of splint which has been put when they were shifting this patient to the hospital for definitive management. Now, with that note, I like to brought this guy who was skiing, enjoying his holidays, and he was coming from a top hill. Suddenly what happens? He was coming in a speed. One of his foot got stuck because under the snow, we don't know where is the rock, where is what. So his foot got stuck here. He was coming with a speed, super speed. Now he cannot lift it even. He's stuck here. Now just focus across this right leg, knee, and see at the ankle and what are the different things are occurring. So now look at it. There is, because this foot got stuck, so there will be some rotation. As a result of that, the forces are acting in this word and the whole body weight is pushing him downwards, and look at it. This is stuck, so it opens further. So as a result, there will be a twist. You remember the word twist? Rotation, standing. So I'm sure we are guessing what is happening here. So now, the forces are acting. A lot is occurring at the knee joint of this gentleman. And there are the forces. This is the gravity, his inertia. Everything is working now. And now there is more rotation. Foot got stuck. And more rotation. As a result of that, he might destroy his ankle. But something more is happening. Injury for sure occurring. There is a rotation occurring at the knee. And it is sudden. It's a flicker. So injury is here. So now injury to the medial aspect of the knee. Are we good? So look at it. Look at it very carefully. Now, look in this image where we were talking about. Unhappy triad of the knee. Somebody has put this topic in the labs, and I'm sure you have done this task. You're familiarized with that. Nothing new. Now look at it. What is this unhappy triad of the knee? Just consider that situation. Force abduction and external rotation of the semiflex knee with the foot planted on the ground. It results in injury classically known as unhappy triad of the knee. The triad of structures injured include arteries, cruciates, medial collateral ligament, and the medial meniscus. So this all together, collectively the term used unhappy triad. Now what happens? Forces are here, lateral forces, and then a resistance of the body, force abduction because of this lateral rotation. So it was not planned, but he was in an inertia, he was in a speed. So this all happens. And then we saw that he had a stretch due to this rotation, due to this force abduction. His medial collateral ligament, his tibial collateral ligament was stretched to its max. It stretched to max, it got a tear. But we all know this medial collateral ligament or the tibial collateral ligament is not alone. It's connected to the meniscus. So it results injury of the meniscus as well. And it's not here. There will be more we talk about. So there is a rotation and this will cause a max stretch. We talk about when the knee is in extended format. So this is at its max. The stretch is a lot on the anterior cruciate ligament. So the forces were so strong that they were able to cause significant damages to the tibial collateral ligament, to the medial meniscus. So how we can think it can be spared? No, and there was rotations. As a result of that, what can happen? The combination of the force abduction, external rotation, slight flexion of the leg causes a tear in where? My ACL. So ACL is gone. And what are the factors responsible for this ACL tear? Never forget. Force abduction, external rotation, slight flexion of the leg, and they causes all this. So these are the factors, these are the keywords which brings injury of this. So this is gone, this is gone, this is gone. So we connect unhappy triad. So when these strong ligaments are gone, what do you think about vessels? What do you think about other soft tissues? So there must be a severe injury. Now look at it. We are good with this. We explained it before. So now forces, rotation, rupture. We have explained it. Rupture. We talk about. And now, when there is a rupture, blood vessel will rupture. So as a rupture of that, within the synovial cavity, synovial fluid, now it is filled with blood. And what is the name? Suggest a name for this situation. Blood heme. Heme arthrosis. Joint cavity is full of blood. This is called, clinically this term is used, heme arthrosis. So now, this person is really worried. He had his finals. He was planning to participate in a skiing competition. Now he's really worried and he is visiting you and he's inquiring. His biggest question is, doctor, what will happen? Will I be able to participate in the upcoming? And what do you think? What has happened? What went wrong? So how a doc will answer? How a doctor will answer? So a doctor should have a good knowledge of anatomy. He should be having a sound knowledge of that blood supply of the meniscus and healing after this injury. So you can predict from these factors if you are clear about. What are these factors? The outer core of my menisci, both lateral and medial. Why I'm showing medial? Because injury is occurring on the medial side. So now the cortical areas, they have their blood supply. Capsular vessels supply here. But this zone, there is no blood supply. There is no artery. There's nothing here, because if there is any, because of the weight of the body, it could have compressed and a joint have all the time in the status of hemarthrosis. So now, if the injury was here in the outer core, it was okay. But now injury, if the injury is deep inside, then you should always say that it will be delayed type of thing. So now, this is what we have inside the joint space. We have synovial fluid. So through the process of diffusion, the inner core of my cartilage, meniscus, getting its nutrition. And this is a very slow. So if injury is in the inner core, remember, the healing is very slow and progression of disease is very slow. So you can say it takes longer period. But cortical area, yes. Look guys, it's not necessary that you will wait for it. There are so many treatment options. But as I have discussed earlier, I'm not talking about the treatment plans and all that. But we should be remembering that the peripheral portion of the menisci are richly vascularized and the vascular vessels are supplying there. But the central avascular portion nourished by only synovial fluid. So this is not that fast. This is not that rapid. So injury in this central zone of my cartilage has a poor healing. That concept has to be very clear. Are we good with that concept? If you are good with this point, then you can play around with the upcoming things. Now, this person is there. Any person where you are examining the lower limb, especially the knee. So what this person is doing, the leg is being straightened up. And now 0-degree extension. And what is that? Flexion at 140 degree. Yeah, these are the degrees. It's okay. You can measure it. No rocket science. But what is this happening? Somebody is feeling for what? Collateral ligament. So when you are examining any part of the body, what are the rules? And especially in the knee examination. Usual sequence. Look, feel, move, and then you have special tests. What are these special tests? You can ask for an X-ray, ask for an MR. CT is not usually, MR is a better option because soft tissue things. And a neurovascular assessment because that is important. We need to evaluate in the first place. Some artery has ruptured, some nerve is gone. So if we can intervene, guys, never forget. If your brain knows something, you'll look for it. And if brain doesn't know about something, you'll never look for it. Somebody, oh, this person has dislocation of the hip joint. Okay, we will fix him. But if my brain knows that posterior dislocation of the hip joint is associated with an injury to the sciatic nerve, and if it's not, attention is not taken, treatment is not started in a short time span, there are fair enough chances of sciatic nerve injury. And sciatic nerve injury means no more hamstrings, no more leg movement. So all is gone. So time does matter here. So this is important when you're handling with trauma, MSK related trauma. You should look, feel, move, and neurovascular assessment. These are important landmarks. Now, what is this happening? For anterior cruciate, there are so many tests, guys. If you're not good with Lachman test and what test and not, it's okay. But you can see that the person who's examining, he's just feeling for that. But that's important. This is what is happening. He is sitting on the foot and he is pushing the tibia backwards. And if this is damaged, look at it. If this is damaged, it may go a lot. We talk about in the previous presentation that what is the job of these cruciates. So this test is called posterior sag or draw test. So this, what he was evaluating, evaluating posterior cruciate ligament. So mechanism of injury, some dashboard injury. Look at it. Even you can see. I use the term look. Look at this line. This line is more straight and this line is bumpy. It is a dip. So it means this has gone backwards. So means my ligament is not fine. There is something wrong. So when I'm doing this test, it go backwards. We call it posterior sag. And this is posterior drawer test. You're closing a drawer. Never forget it. We ask a lot about this. What this doctor is doing here. Is he doing posterior drawer? No. Look at this arrow. He's pulling towards him. So he's looking for ACL. Previously he was looking for PCL. So ACL. and mechanism of injury, what happened. So asking from the patient what went wrong, what was the event. So it's a big clue. So this is the anterior draw test for done for anterior cruciate ligament. The previous one was posterior draw test done for the integrity of the posterior cruciate ligament. Now, guys, another important concept, the bursas around knee joint. We have so many. I'm not talking about all of them, but we are good with that. No rocket science. We know that this is the posterior capsule, joint capsule. With the red, I have drawn the synovial membrane, posterior part. And what happened? This is the infrapatellar fat. Look at it, what goes? The synovial membrane from the anterior aspect is being pulled all the way up. Who pulls it up? What force? Think. And this is the fluid. Now you remember? I used a term in the first presentation. This is the suprapatellar bursa, which is continuous with the joint capsule. Inside of the synovial membrane is continuing all that. So now, synovial fluid is filling up even this space. So, if I have to access, you remember I was showing you from the vasti, I can insert a needle and I can withdraw the fluid for diagnostic purposes. I need not to go through this complex, delicate ligaments because my needle may cause a trauma to the cruciates, to the menisci, and these are very precious structures and we have to save them. So the best thing is, you can, if you want to tap, if you want to get this fluid, no need to get from here, you can get from there. You want to give some intra-articular injection, you can give it here, it will come, medicine will come down. It will be as good, you may enter from here. But if you're entering, this is the safest part. That's why I was showing this in the first part of my knee joint presentation. So that's the safest site. Preferred site for joint injection and aspiration. So if somebody has to be given an injection in the joint, you can go from here. No vascular thing, no important ligament can be damaged. So it's a safe area. From where? From the vastus lateralis or medialis, but not in the midline. So now, who pulls it up? There is someone. What muscle is this? Think. Guys, we haven't talked about it. This is articularis genu muscle. And its only job is to pull this. It's pulling it up. Its only job is to pull this synovial membrane. Now, this bursa is in front of the patella. What do you call it? Pre-patellar bursa. This is below the patella, but this is deep. Deep. This is superficial. Both of them what? Inferior. So this is under the skin and this is deep. No rocket science. And they are called infrapatellar bursa because this is my patella. They are below the patella. One is deep, one is superficial. Are we good? Now, sometimes some people have this. The fibrous joint capsule becomes weak and synovial membrane pops out. This condition has a name to it. It has so many names, we call it popliteal cyst, but it is famous as Baker cyst. I don't know why it's called Baker cyst. There are reasons, but no need to go in those details. So this is what Baker cyst is. This is the extension of the synovial cavity into the popliteal fossa under the skin, not outside the skin. It's a defect in the posterior capsule, and this is called Baker cyst, and this causes swelling in the popliteal fossa, and it causes what? Inflection movement, it causes problem, and popliteal cysts usually occur in association with those who are suffering from rheumatoid arthritis or gouts. Gout is a very common disease occurring in this part of the world where we are. So this is a commonly occurring thing. We need to be good at it. So bursitis, we talk about that so many times. I'm sure now everybody should be good. This is just a revisit. Which muscle is responsible for flexions, which group of muscle for the various movements occurring at the knee joint. And this is what you're looking at. How this PCL injury, we talk about that. Posterior draw test, we talk about that. Look at him. Rotation, we are good with that. ACL, just a quick recap. Knee joint, guys, this is a key slide. But type of joint, capsule, ligaments, intra-articular structure, stability, movements. Thank you very much. Stay safe, stay connected. Bye-bye.